Good afternoon, everyone. My name is Nadia Dghaich, and I'm a Health Education Officer with the Multicultural Health Service from the Illawarra-Shoalhaven Local Health District. Today, we've heard a lot about some of the great news that's been done around the state to help lessen the impact of cancer in our communities. And it's working. Survivorship rates are up 69%, are up 20% to 69%, meaning that those diagnosed with cancer today have got a 69% chance of living 5 years after their initial diagnosis. These are really significant improvements, but we're still a long way off for those in our culturally and linguistically diverse communities. My presentation today is really about starting a conversation on how we can work together and becoming more culturally responsive in order to address the inequity facing those from our CALD communities affected by cancer. So a little bit of background information for you. According to ABS data in the state of New South Wales, a quarter of our population was either born overseas, has a parent born overseas, or they speak a language other than English. So it's fair to say that we are quite culturally diverse. Some of you may be asking, what does this have to do with cancer inequity? A lot. The stats tell us that CALD community members that are affected by cancer don't do so good. According to the literature, Cancer Australia and Cancer Institute, CALD communities have a higher incidence of cancer, a later presentation, and a lower rate of survival. Why? The truth is, we really don't know. There's a range of social determinants and modifiable risk factors contributing to the poor health outcomes of our CALD community members. At this point, much of the literature available is formative, and the availability of data to allow a clear delineation between CALD and non-CALD within the health service is virtually non-existent. What we do know is there is an unspoken stigma surrounding cancer within the CALD communities, and there is a sense of marginalization and social isolation that afflicts those affected by cancer in these communities. Over the last 18 months, our service has been supporting the implementation of Project SAHA, a partnership with the Sisters Cancer Support Group and the Multicultural Communities Council of the Illawarra. Project SAHA was funded by the Cancer Institute as part of the Innovations in Cancer Control grants in 2017. The aim of the project is to improve the quality of life of Muslims affected by cancer, by sharing the stories of survivorship in the SAHA video series, improving access to support services for those affected by cancer, and promoting healthy living through a holistic approach to health and well-being, and also increasing awareness of service providers and working with the Muslim community. And for those of you who don't speak Arabic, SAHA is more than an acronym. It actually means health and wellness in Arabic. This is a really packed slide, sorry. I was trying to get all the phases of the project onto one slide. So there's essentially 4 phases of this project. The first phase was entailed literature review. This is where we did all our research, find out what's out there and exploring some of the equity issues that are facing our CALD communities. We reviewed 16 publications, 2 of which were a meta-analysis, which formed the evidence base for our funding application and the ethics application for future research. The second phase of the project was the engagement, which required extensive community consultations with stakeholders. We conducted 2 focus groups and 10 informal community consultations and 4 full 1-hour interviews with cancer survivors. The data we looked at explored access issues and barriers, the patient's experience through the cancer journey across 3 health districts, and the perceived beliefs, attitudes around cancer in their community, and the concept of survivorship in a post-treatment phase of cancer, which then led us to the development phase. At this phase of the project, really, we were analyzing the data that we've collected, using thematic analysis to draw out key themes and critical findings. We used this data in the development of the SAHA video series. The data also shaped our social media campaign and provided us with some information on what to use in critical targeted messages for this community. It also provided us with a framework and content for the Sisters Cancer Support Group website. All the resources were tested with members of the community affected by cancer and with the local health services. So we're now in stage 4 of the project, which is the dissemination phase. And this is really where the project outputs are delivered to the community and the stakeholders. The social media campaign launched in late April, and it increased Facebook engagement by over 120%. The SAHA Health Forum was a dual-purpose event held in May with two key objectives. The first was to launch the SCSG website, and the second was the SAHA videos. Second, to bring service providers, the second objective, of the forum was to actually bring service providers in the Muslim community together to challenge unconscious bias and open people's cultural filters for future conversations about culturally responsive care. Conference presentations like today and community catch-ups are lined up in the next fortnight across Southwest and Western Sydney local health districts. And as the name implies, these are informal catch-ups to speak about what the cancer group does and send out the messages to the community around what SAHA was aimed to achieve. So for those of you who want more information about the Sisters Cancer Support Group or the upcoming catch-up sessions, please check the Sisters Cancer Support Group Facebook page. I really love this image. It's a great visual representation of the difference between equality and equity. It really reinforces that the one-size-fits-all approach really means that not everyone will have the same health outcomes if they're given the exact same level of care. In an effort to understand the underlying factors of inequity, we uncovered many parallels between the Muslim community and those from CALD communities. Equity issues were not limited to English proficiency, difficulties in navigating complex health systems, and low levels of health literacy. Now, we did slightly talk about health literacy, but I just want to elaborate on it a little bit more. Health literacy is more than just understanding what it is that's making you sick. It's really the capacity of the individual to obtain, process, and understand basic health information and services in order to make appropriate health decisions. During one of our consultation sessions, one cancer survivor openly admitted to not really understanding what cancer is and why she had to have chemo. This was absolutely shocking revelation to hear in an age when we expect individuals to be able to manage all facets of their health. That being said, these issues are across the board, across all CALD communities. Sociocultural barriers are social and cultural issues that are unique, and in specific with the Muslim community, there are contributing factors to inequity in health outcomes. Until recently, it was very rare to find a hijabi, or a veiled Muslim woman, fronting a screening campaign or a service promotion. The images we use to attract our target group in our marketing and messaging campaigns are aimed at resonating with a specific target group. But not having representation is equally impactful. There is an unconscious switch that turns off in our mind that says, "This is not for me," resulting in an almost instant disengagement with vital life-saving information. This is not exactly the reaction we, as health promotion officers, are looking to elicit in the community. And from a community standpoint, the lack of inclusive marketing adds to the feelings of marginalization sometimes felt by this community. And also specifically in the cultural safety is another area of focus that's contributing to the inequity within CALD and mainstream cancer patients. Cultural safety ensures that individuals have the right to have their beliefs and values responded to in a sensitive manner and have their religion, food, prayer, dress, privacy, and customs respected. To get to the stage where our services are culturally safe spaces, we need to be more than just culturally competent or culturally attuned to the needs of our client. Not doing so can lead to poor communications, misdiagnosis and inappropriate treatment, poor patient adherence to treatment, and the loss of patient trust, increased incidence of racism and discrimination, and poor health outcomes. These are actually taken straight out of the policy and implementation plan for healthy and culturally diverse communities. Throughout the project, it was clear that the Muslim community members were seeking out culturally safe places for support, a place where they didn't have to worry about wearing a hijab or getting up for midday prayer, a place that was free of judgment. The Sisters Cancer Support Group is this safe space for so many women affected by cancer. I've also got religious and cultural beliefs because these are very significant at shaping the health-seeking behavior of those in our Muslim community. This was openly shared and was a significant reoccurring theme in each of the SAHA videos. What we did learn was the perception of illness and cancer within the Muslim community can be any of the four. It is predestined for the individual, so why screen if I'm going to get cancer anyways? Cancer is viewed as being a trial from God, a misconception that you fail the test if you seek help if you're not coping, which I'm reassured after consulting with many imams that this is not the case. And cancer is an expiator of sins. I think understanding how religious beliefs impact health-seeking behavior has shed some light on why we asked the question why earlier today. So just asked to wrap it up. So what can we do as health practitioners? What can you do to improve outcomes for our CALT community? The first is use interpreters. Know when to use an interpreter. Sometimes it's difficult to understand when you should be using an interpreter, but if your client asks for one, or it's blatantly obvious that they have limited English skills, or they're relying on family to translate, you need to call an interpreter. And for clinicians, sometimes you guys forget that interpreters can be as much for you as they are for them. So if you're having a hard time understanding your patient, call an interpreter for yourself. The second is to provide translated and culturally appropriate resources. Have a look online for material that is translated and give those to your clients. Use Teachback. Teachback is a way that you can make sure that the information you give your patients was understood. And it's a really good way to make sure that your client understands what it is you've just told them. And four is enhance your cultural capacity. Open your cultural filters and become more culturally curious. Be culturally curious. Learn about new cultures and customs, and don't be afraid to ask your clients questions. More often than not, it will be well received because it shows that you have a genuine interest in learning about their cultures with the aim to improve service delivery. But not to mention, it also builds rapport and trust in the doctor-patient relationship. Really quick, I will just touch. I've actually reported on the outcomes of SAHA using the Multicultural Equity Framework and how it's met the framework objectives. So in terms of collecting, evidence was collected on the equity issues relevant to the Muslim community in aiding our collective understanding of the Muslim patient experience, service access, and barriers to access. Also an exploration of the beliefs and attitude towards cancer within the Muslim community. In terms of engagement, the project was funded to engage the multicultural Muslim community using a range of innovative approaches. The approaches used was partnership with key community organizations such as the Sisters Cancer Support Group and having them actively collaborate in all facets of the project. The utilization of social media and key influencers, and also using community navigators and consulting with community leaders and cancer patients and families. One thing I wanted to say is we did relax the rules when it comes to engagement. What worked in one district doesn't necessarily work in others. We learned that through this project that the impact of the work that we've done at a service level in the local health district in the Illawarra over 4 years, alongside the Sisters Cancer Support Group, has actually enabled the successful engagement in the Illawarra to occur. The challenges we faced in engaging Sydney wasn't bad or good. It was a critical learning of the community readiness and the service readiness to tackle the too hard basket. Sydney has over 265,000 Muslims, whereas the Illawarra only has 4,600. It is inequitable to continue to ignore the need to have culturally appropriate services and campaigns to ensure that they are inclusive of all social demographics. Leading me to my next point, quickly, leadership. This project really showcased what can be achieved with strong leadership. At a state level, from the Cancer Institute for funding a project specifically focusing on a religious demographic that was never done before. Leadership at a district level, having the support of the Multicultural Health Service and the Illawarra Cancer Care Centre really made the project come to fruition. And leadership at a community level. Sisters Cancer Support Group is a fantastic example of what can be achieved when communities are mobilized and supported to initiate change within their community. So I really want to take this opportunity to thank the entire Sisters Cancer Support Group for their countless hours of volunteer time in bringing Project SAHA to what it is today. So these are just links for anybody who is culturally curious. You can hop on any of those links there. Multicultural Health Communications has got a plethora of translated resources that you guys can use. Information on Teachback, and if you want to watch the SAHA video series, it's actually available in 5 different languages. So please, thank you.